Biopsy in oral and maxillofacial surgery. Contents: Introduction, indications and contraindications of biopsy, types of biopsies, biopsy techniques based on anatomic locations, and the conclusion. Introduction. Removal of tissue from a living person for microscopic examination to confirm or to establish the diagnosis of a disease is known as biopsy. Whereas, if we remove the tissue from a dead person for examination, that is known as autopsy. Sir Ernst Henry, who was a French dermatologist in the year 1879, he first coined the term biopsy. So, biopsy is done to establish a proper diagnosis so that proper management can be undertaken. What are the indications of biopsy? The lesion is more than 2 weeks old. The lesion is not responding to local treatment even after removing the irritant. There is persistent hyperkeratotic changes. There is inflammatory changes of unknown cause that persists for long periods. Lesions that interfere with local functions, such as fibroma. Bone lesions not superficially identified by clinical and radiographic findings. Any lesion that has characteristics of malignancy. To determine the nature of all abnormal tissue removed from the oral cavity, including cysts and granulomas. Contraindications of biopsy. Normal anatomic and racial variations, such as those seen in physiologic pigmentations, leukoedema, linea alba, tori, exostosis, and others. Compromised general health of the patient or history of diathesis, including patient on anticoagulant therapy. Proximity of lesions to vital anatomic, vascular, neural, or ductal structure, and lesions in areas of difficult surgical access. Immediate pre or post radiation therapy. The various types of biopsies are incisional biopsy, excisional biopsy, punch biopsy, cytology, and frozen section. Incisional biopsy is a technique that samples only a particular or representative part of the lesion. If the lesion is large or has different characteristics at different locations, more than one area of the lesion may need to be sampled by this technique. It is usually indicated if the area under investigation appears difficult to excise because of its extensive size, that is, size is more than 1 centimeter in diameter, or hazardous location, or whenever there is suspicion of malignancy. Principles of incisional biopsy. Representative areas of the lesion should be biopsied in a wedge fashion. The biopsy site should be selected in an area that shows maximum tissue changes, that is, at the border of the lesion. Necrotic tissue should be avoided as it is useless in diagnosis. The material should be taken from the edge of the lesion to include normal tissue as well. And care must be taken to include an adequate amount of abnormal tissue. It is better to take a deep, narrow biopsy rather than a broad, shallow one because superficial changes may be quite different from those deeper in the tissue. Excisional biopsy, it implies removal of the entire lesion. A perimeter of normal tissue surrounding the lesion is also excised to ensure total removal of the lesion. Indications of excisional biopsy are excisional biopsy should be employed with smaller lesions, that is, lesions that are less than 1 centimeter in diameter, that in clinical examination appears to be a benign lesion. The entire lesion, along with 2 to 3 millimeter of normal appearing surrounding tissue, is excised. Punch biopsy, it can be either an incisional biopsy or excisional biopsy, but usually a variant of an incisional biopsy which uses a special punch type forceps for the removal of a portion of the lesion. In this method, the surgical instrument files out small segments of tissue from inaccessible lesion or from large lesions where excision is contraindicated. The principle of punch biopsy. In this method, the punch is held perpendicular to the skin and is gently rotated with firm downward pressure. The punch is pushed down until the subcutaneous fat is reached. The incised column of tissue in the punch is lifted and the pedicle is cut. The tissue is then carefully removed from the punch. Cytology, it is a useful tool to screen and diagnose various pathological lesions in the body without causing significant trauma to the patient. Microscopic study of cells obtained from the surface of an organ or lesion after suitable staining. The cytopathology methods are of two types. They are exfoliative cytology and fine needle aspiration cytology. Exfoliative cytology. The neoplastic cells are less cohesive than the other normal cells in the body, and usually they shed on the surface of the lesion or into the secretions. The shed neoplastic cells are obtained from the lesion by scraping its surface and are then evaluated for possible changes like dysplasia. The technique of exfoliative cytology. Firstly, all the surface of the lesion is cleaned by removing all the debris and mucins. After that, gentle scraping is done on the surface of the lesion with metal cement spatula or a moistened tongue blade for several times. Thus, the materials present on the surface of the lesion are adhered or collected at border of the instrument. The collected material is then evenly spread over a microscopic slide and is fixed immediately with 95% alcohol. The slide is then air dried and is stained by a special stain called PAP stain. Indications of exfoliative cytology. In case of herpes simplex, herpes zoster, pemphigus vulgaris, pemphigoid, squamous cell carcinoma, aphthous ulcer, candidiasis. The advantages of exfoliative cytology are anesthesia is not required in this technique and it is most useful for detection of virally infected cells, acantholytic cells and candidal hyphae. It is a quick procedure, simple, painless and bloodless procedure also. Special procedures like immunohistochemistry can be performed in exfoliative cytology samples. Disadvantages: it is unreliable for confirmatory diagnosis of cancers as large number of false negative test results are often found. FNAC is another type of cytological examination. It stands for fine needle aspiration cytology. It is a technique whereby cells are obtained from a lesion using a thin bore needle and smears are made for cytopathological diagnosis. This technique is based on the fact that tumor cells are less cohesive and are easily aspirated. FNAC helps to diagnose lesions in the oral cavity, floor of the mouth, tongue, palate, tonsils, thyroid gland, cervical swellings, and posterior pharyngeal wall swellings. Advantages of FNAC. It is a simple office technique. Rapid diagnosis is possible. Economical. Sampling from multiple sites in the same sitting is possible. It has high diagnostic accuracy. Many techniques such as bacterial culture, immunocytochemistry, flow cytometry, cytogenetics, polymerase chain reaction are possible from FNAC material. The limitations of FNAC are: there is loss of tissue architecture, capsular invasion and lymphovascular lesions cannot be detected, difficult to differentiate in situ versus invasive carcinoma, considerable training is needed for accurate interpretation. Indications of FNAC. In case of salivary gland swellings, FNAC of the salivary gland is helpful because it often differentiates benign from malignant swellings. It thus changes the management. Lymph nodes such as tuberculous lymphadenitis, chronic inflammatory lymphadenitis, secondary metastatic lymph nodes, malignant lymphoma, Burkitt's lymphoma, Hodgkin's lymphoma, non-Hodgkin's lymphoma, oral oropharyngeal, buccal, tongue and thyroid lesions. Types of FNAC. FNAC with aspiration and the second one is FNAC without aspiration. So FNAC with aspiration, the needle is passed into the lesion and negative pressure is applied, usually by virtue of a syringe attached to the needle. This method is particularly useful when draining a liquid from the lesion, like in case of a cystic fluid, ascites or pleural fluid. It is important that the negative pressure is released prior to exiting the lesion. If this is forgotten, after exiting the lesion, the material from the needle may be accidentally aspirated into the syringe and it becomes very difficult to expel it. The needle is then detached from the syringe and the material is expelled onto a glass slide. Next is FNAC without aspiration. Based on the observation that the capillary pressure in fine needle is sufficient to keep the detached cell inside the lumen of the needle of FNAC without aspiration, also called as fine needle capillary technique or non-aspiration technique. The needle is passed into the lesion and multiple fast jabbing movements in and out of the lesion as well as in different directions are performed. Once the material is seen in the hub of the needle, there is usually sufficient material. Failure to obtain a representative sample if the needle has missed the target tangentially, if the needle is in the central cystic or necrotic or hemorrhagic area which is devoid of diagnostic cells, if the needle is in the dominant benign mass missing a small adjacent malignant lesions, or if there is fibrotic or desmoplastic target tissue giving a scant cell yield. Method of FNAC. Thin needle, generally 22, 23, 25 and 27 gauge needles are used for the performance of aspiration biopsy, most often 1.5 inch in length. First of all, palpate the mass, attempt to determine its location in relation to the surrounding structures, estimate its depth, decide on the optimal direction of the needle to accomplish the aspiration biopsy. The patient should be placed in a comfortable position for the aspiration biopsy procedure. The mass located deeply in tissues is usually best approached perpendicularly to the skin surface. FNAC material may be expelled directly into a transport medium like cytolite and sent to a laboratory for further preparation. Cytolite is a methanol-based buffer preservative solution which is used to support cells during transport. For deep-seated lesions, radiological guided FNAC is required. The deep-seated lesions can be aspirated under the guidance of ultrasonography, computerized tomography, magnetic resonance imaging, fluoroscopy, ultrasound-guided endoscopy. USG-guided FNAC. It is useful in the staging of head-neck lesions. Image-guided FNAC is particularly advantageous in cases of small, non-palpable or multiple lesions. The depth of the lesion from the skin surface is measured to determine the length of the needle required. Continuous real-time ultrasound is used to visualize the needle entering the lesion and also during aspiration to ensure that the needle stays within the lesion. Advantages of USG-guided FNAC are: it is a real-time view, portable, no radiation exposure, angular approach can be done, and it has better precision. The disadvantages are: significant obscuration due to air or bone may affect the image. It has not very high resolution and it is completely operator dependent. Frozen section biopsy is a quick method of diagnosis. It is used during surgery to make sure that the margins of the lesion are clear. It allows a stained slide to be examined within 10 minutes of taking the specimen. The tissue is sent fresh to the lab to be quickly frozen at -70 degrees Celsius by immersion in liquid nitrogen or dry ice. A section is then cut on a refrigerated microtome and stained. The reporting time should be 20 minutes. The specimen should be sent fresh without formalin. Indications of frozen section biopsy are urgent diagnosis during surgery, like in case of to rule out benign or a malignant lesion, involvement of resection margins by malignancy. Next is bone biopsy. So before a bone biopsy is performed, the surgeon should obtain good quality imaging studies. Radiolucency lesions. Determine the nature of the radiolucency. Obvious periapical pathosis need not to be subjected to biopsy. Small radiolucent lesions have a well-demarcated border. It may be enucleated in total and sent for biopsy. Central granulomatous lesions not associated with periapical pathology should be submitted for microscopic examination before definitive treatment is instituted. Large radiolucencies should be first biopsied and a diagnosis established before a definitive treatment is undertaken. The sequelae of opening into an unsuspected vascular tumor are very serious and will result in severe morbidity. All radiolucencies of the jaw are aspirated as the first step in developing a working diagnosis. Vascular lesions should always be ruled out. Aspirational biopsy. A 16-gauge needle attached to a 10 cc disposable syringe is used to penetrate into the radiolucent lesion. Negative pressure is applied to the syringe and the contents of the radiolucent lesions are removed. Aspiration may be either nothing, like in case of a solid tumor. It can be air, like in case of traumatic bone cyst. It can be a straw-colored or blood-tinged fluid, like in case of a cyst or ameloblastoma. Or it can be fluid with keratin needles, like in case of odontogenic keratocyst, or also it can be blood, like in case of a vascular lesion. Now we come to the radio-opacity lesions. The well-defined radio-opaque lesions like odontoma may be removed in toto as excisional biopsy. For diagnosis, the excised material needs to be fixed to stop tissue autolysis prior to the sample reaching the pathology laboratory. The solution of choice to do is 10% neutral buffered formalin fixative, which is a 4% solution of formaldehyde. Biopsy techniques based on anatomic locations. This I will discuss in the next video.